the worst advice that you could tell someone with osteoarthritis is to rest.
That's a brief snippet from Dr. H.J. Lukes, our orthopedic surgeon who joins us on today's episode of the Catalyst 360 podcast. And we're going to talk about all sorts of elements when it comes to knee replacements, hip replacements, knee injuries, osteoarthritis, all those components, and getting his perspective, which I think you'll find quite refreshing, as you heard just a little bit right there. 5% of the U.S. population will have a total hip replacement by age 80, and another 10% will have a total knee replacement. Those are big numbers. That influences both athletes and non-athletes alike, and it creates this natural curiosity on a number of fronts. Is it inevitable? Are there things we can do to reduce our odds of needing that? How quickly should we move forward towards surgery when experiencing the pain? How active can we be post-surgery? Today, we're going to talk about all those things with Dr. Lukes. He's the author of Longevity Simplified and is a great follow on Twitter. And while I've known hundreds of surgeons during my years as a physical therapist, Lukes brings a very fresh, new, myth-busting perspective that I'm certain will open your eyes to new options that maybe you hadn't previously considered. And at a minimum, it provides a wonderful resource for those of you who are either facing your own journey with a hip or knee replacement or arthritis and what that might mean, or if you're supporting someone else, a parent, family member, spouse who's considering the same. Welcome to the Catalyst 360 podcast. I'm your host, Dr. Brad Cooper of Catalyst Coaching 360, and you're going to love what follows. He is one of those rare returning guests we've had join us. This is his third visit, which makes him one of only 2 people to ever join us 3 times over our 320 plus episodes. We've got a big announcement for employers, EAPs, and wellness service providers. Catalyst Coaching 360 was just approved by the U.S. Patent and Trademark Office for the nation's only trademark coaching service, the 360 Wellbeing Checkup. This low-cost, high-value option helps support and enhance the physical and mental well-being of your employee team members in a personalized, credible, and meaningful way. If you'd like to learn more about the only coaching organization to be awarded a trademark for their coaching model, please reach out anytime. Results at catalystcoaching360.com or visit the website catalystcoaching360.com. And now, it's time to replace surgical myths with practical realities as we tap into the wisdom of Dr. Howard Lukes on the latest episode of the Catalyst 360 podcast. Well, Dr. Lukes, good to see you. Well, we want to bring you back to talk about hip and knee replacements. We're getting a lot of those questions of, how does endurance sports influence it? Are there things I can be doing in my 30s and 40s that reduce the likelihood of that? What are some of the signs and symptoms I look for? Should I wait? Should I jump into it? So out of the gate, just maybe what have you been learning over the last, you and I are similar ages. I think we actually share a birthday, but you're about 4 years older. What have you picked up, having been a surgeon for, a good 30 years, over the last 15 or 20 years that maybe you didn't have that perspective early on?
Yeah, sure. Well, it's a pleasure to be here. I always enjoy talking to you, and I'm always jealous at the pace that you've been able to bring into your late 50s.
Hanging in there, brother. Hanging in there.
The longer I've done this, the more my thinking has changed. As clearly, anyone who's reached this point in their career realizes that there's much more that we don't know, right? The more we know, the more we know we don't know.
Completely.
And certainly osteoarthritis is right up there with one of those diseases we just know so little about. As we were not, or at least I was not taught the cause of osteoarthritis in medical school. And if I was, it was probably wear and tear, or I might have been on the basketball court that day. But one thing that's clear is that wear and tear is really not the cause of osteoarthritis, period. Now, can it compound issues that have already started? Sure. right? So especially, if you have bow leg or knock knee, then you're predisposed to developing arthritis.
Yeah.
And pounding on those knees might not be the best idea. However, honestly, we can't say that either. But we know that, for example, runners don't have a higher incidence of osteoarthritis.
Right.
Now, am I talking about people who routinely do 100-mile runs? No, but we don't actually know about that group because there's not enough to study. But with people who run on average 20, 40 miles a week, we're not seeing an increased incidence of osteoarthritis. We know that genetics is a significant cause and contributor to the development and progression of osteoarthritis. Why? Cartilage, contrary to popular thought, actually does have innate healing mechanisms. And there's a lot of genetics involved as to what constitutes the function of those repair mechanisms. And things can go awry in various genes that will predispose you to osteoarthritis because of the failure of cartilage to heal from microtrauma, let's say. Next up, one of the largest contributors to osteoarthritis, especially in terms of progression these days, is metabolic disease-associated osteoarthritis. Now we're opening up a can of worms.
Yes.
Because what do I mean by metabolic diseases? So any disease that really involves poor energy processing. So we're talking about poor mitochondrial function, poor cellular respiration, poor mitochondrial flexibility, which is the process where your body prefers to burn fat over glucose. So type 2 diabetes, fatty liver, and the downstream consequences of these diseases can have dramatic effects on every organ in the body, and our joints are not immune to that. Why? Well, these diseases in general tend to create a highly inflammatory environment in our body. That's why they contribute to the risk of heart disease, because high LDL or ApoB cholesterol is necessary, but not necessary and sufficient to cause atherosclerotic heart disease. You need the presence of inflammation to oxidize that fat burden. Well, with these inflammatory mediators that are circulating around the body, find their way into our knee joint. We all know that we have some fluid in our knee joints. We need it much like we need oil in a car.
Right.
But cartilage doesn't receive a blood supply. So cartilage derives its nutrition from the fluid in our joint. So if you're metabolically healthy, then the constituents that are found in joint fluid will mirror that in your blood. So if you have healthy components and chemicals and compounds in your blood, low in inflammation, your cartilage in general is going to be healthier. If, however, you have a high inflammatory burden, a lot of nasty cytokines and interleukins, they're going to find their way into our joint fluid, and they're going to affect the integrity of the cartilage on the end of your bones. So the cartilage will not derive as much nutrition as it needs. It won't heal as well, and it can cause progression. Furthermore, and perhaps worse for everyone's day-to-day existence, is that if you take people with poor metabolic health and moderate arthritis, so it's not severe yet, it's not really mild, compared to a runner with moderate osteoarthritis, there's a good chance the runner doesn't even know it, or they have a mild ache at the end of a long run, or some aching in the morning. But there's a really good chance that the person who's a little overweight, has fatty liver, insulin resistance, et cetera, that they have a lot of pain, because this can really stir up a lot of inflammation within the joint.
So
you
same
have
condition.
more pain.
If you're looking at it on an MRI or something, and we can get into MRIs later because I love your attitude on that too. But same picture. But person A is saying, yeah, maybe I'm a little sore after I go for a run or a hike or whatever. The other person says, it just kills me.
Yeah, it can be that significant. I can be in the office looking at someone who's there because they're thinking about whether or not they need a joint replacement because of their pain. And I'm not seeing that runner or endurance athlete because they don't have enough pain to want to see an orthopedist.
Right. And I've noticed personally, and I've heard other people say this too, that sometimes the pains come up when we decrease frequency. So when I'm doing something every day, maybe it's on the bike, maybe it's a run, maybe it's a gym session, whatever, I feel better. I don't notice any of the aches and pains, or you're just kind of like, oh, there's a little something, but it doesn't bug me. And when I'm on vacation or I come back from vacation or something, I'm like, you know what? That's kind of sore. And I've done less. Is that part of what you're talking about? It's the fluid that's moving through the joints. Is that part of that, or is that unrelated?
Sort of. It is. So everyone, no matter how healthy you are, we have more chemicals and compounds in our joints that are pro-inflammatory when we're sedentary. I don't care how healthy and how active you are. And we just don't like being still. I mean, it's almost comical. You know, when I get up in the morning and the dogs wake me up and I go to the bathroom, I can barely walk. Right? And I'm tiptoeing around. My ankles hurt, my hip, my knee.
Have you been reading my journal? Yeah. What's going on here, Doc?
Yeah, but yet I get coffee, I walk the dogs, and then I can go for a run. Yeah. And so Paul and I just put out a podcast the other day, and it says, your first mile sucks, or the first mile sucks.
Yeah.
Or the first mile you ride, or whatever.
I saw that.
We all know that feeling, right? And as runners, we also know that feeling when we hit the trailhead and we start running. You're just not feeling it, right? But if you stick it out in 2-3 miles, you're going to feel fine. Yeah. And you get that warm feeling. Something happens, right? And you I'm in the zone, and now I can go for it.
I'm good. Yep.
So you have to just wait for that. Because it's too easy sometimes, when you first wake up or you first hit the trail, you first get on the bike, to jump off. Your brain is telling you, you don't have to do this. You don't have to do this.
Yeah. And so many people don't get past that.
You're absolutely correct.
I mean, you do, because you know the history. I'm going to feel better. I'm going to feel good, not just fine. But the beginner doesn't. They're like, oh, I'm not supposed to do this. Oh, it hurts my knees. Oh, I'm too old for this.
Might be causing harm.
Yeah.
Right. Yeah. But there is a scientific reason why we feel like this. I mean, you don't have the necessary proteins or enzymes built up to a certain concentration when you first start an effort, right? Why would your mitochondria and your cell produce all these enzymes if they're not needed? Yeah. Right. It doesn't know you run at 7:00 every morning.
Right.
So when you first get started, it's revving up, the mRNA and protein and all the enzymes. So you're really priming the pump at the cellular level or microcellular level. You're also priming the pump at a muscular level, getting all the actin and myosin chains ready to go, getting your energy systems ready to go. And your body, on the macro level, you're washing out all these pro-inflammatory compounds from your joints.
And let me just describe that for the listeners. When he says washing out, it's almost like, and correct me if I'm wrong, but it's like a pumping mechanism. As you're moving, that's creating that pump that's moving the blood flow, the fluids through the joints in the way that you're wanting to go. Is that a layman's term description that's accurate, or am I missing?
That's very accurate.
Okay.
No, that is quite accurate.
So keep going. I interrupted you. Keep going. I've got a whole list here, but I don't want to stop your flow there because that beginning of the day, it's not feeling right. We're out there. How does that differentiate between these folks? And then how does that point us to or away from this idea of, oh my gosh, I think I need a hip or a knee replacement?
Hopefully we're far away from that point, but we'll get there. Yeah, let me get back to my train of thought. But where a lot of people run into trouble here is they overreact to these aches and pains, right? We have the risk equation all wrong. And we have the risk equation all wrong in many aspects of our lives, right? Most people fear shark bites more than a mosquito bite, right? But yeah, we fear the risk of injury far more than we fear the risks or downstream consequences of being inactive or sedentary, right? But we know, there's so much data out there that the risks of injury in runners, athletes, soccer players, etc., is really low.
Right.
Given the amount of activity. Yes, runners are going to get hurt.
Right.
So are soccer players. But if our body broke down easily, a soccer team would have to have a roster of 200, right? Because everyone would just be injured all the time. Yet we know the downstream consequences of being sedentary. We know that you'll become insulin resistant. We know a fair number of those are going to get type 2 diabetes. If you're under 50 or 55, that's going to take 10 to 12 years off your life. It's going to increase the risk of, kidney failure, dementia, heart disease, stroke, and so on. And osteoarthritis and the pain of osteoarthritis and the disability of not being able to move, which now will compound the problem even further. So it's very easy to overreact to these aches and pains. And look, I mean, given what I do and how many people that I see and treat for this, there are days when I have an ache or a pain and I go running on a trail. And more often than not, that ache is gone within a mile or two. Sometimes it's not. So I'll slow down or I'll stop, I'll turn around and I'll walk back. Right? I mean, I'm not an idiot. I'm not saying that
we're not
pain,
bulletproof.
Requires an evaluation. But I'm saying that most of the times it doesn't. Swelling tends to scare a lot of runners too. And I'm sure you've had this, I've had it, but a lot of us will just develop a swollen knee. We don't remember the injury. It just sort of came up on us.
Yeah.
And it's very easy to overreact. It often will last for months. We assume the worst. And maybe we'll get an MRI. Maybe we'll get some other things. We'll find things because every runner's knee has things in it. And we want to overreact because we want to get back out there. But most of the time, you can get back out there. You don't have to wait for the swelling to go away. And it's going to take 2-3 months to go away. So,
But don't be stopping in the midst of okay, so someone's listening to this and they're saying, okay, I do have that swelling. It doesn't hurt to run, but then it swells afterward. Should I stop until that swelling is gone? Everyone, this is not medical advice. Even though he's an orthopod, he's not seeing you. He's not doing an objective exam. He's not doing your subject. So don't take this too far, everyone. But generally speaking, for that person, would you say, again, limited view of what their real situation is, but would you if it were you, if it were me, would you say, you know what, Brad, go out, go ahead and run. If it doesn't hurt more, if it doesn't swell more than X percent, is that the kind of guidance you give, or would you say hop on a bike for a month? Let's just shift from running. Let's jump over to the bike. Let's jump on the elliptical, whatever. And when the swelling stops, then go back. Like what kind of general guidance might someone take in who's hearing that?
Sure. Yeah. First of all, very few runners are good cross trainers, and they hate it. So I try to keep runners running. So there are two subsets here. One are generally guys like you and me, middle age, upper middle age, wake up one day, the knee is swollen. Really don't have any osteoarthritis on X-ray. If we got an MRI, we'd find some.
Of course.
Because age is the number one, number two cause. And we don't know why these knees swell, right? Something just annoyed the inside of the knee. That's how the knee reacts. When the knee is cranky, it produces fluid. Not always causes pain, but it produces fluid. And very often, this fluid is not due to any structural abnormality. It's not due to the inflammation in the bone that we see on your MRI. It's not due to the degenerative meniscus tear that we see on your MRI. It's not due. It might be due to the mild osteoarthritis, right? Because that can cause this. But by and large, this swelling is not due to a troublesome, problematic mechanical issue that requires rest. So unless there's so much fluid that you can't straighten the knee, you can't bend it enough to run, I'm going to say run. Okay. This isn't the time to run events or set PRs or go long. Sure. But, if you're like us and you need to run to feel whole, go outside, run. The other group is a group with known osteoarthritis, enough so that they've come into the office on occasion for evaluation. And osteoarthritis commonly will cause some swelling and obviously some pain. But osteoarthritis is not worsened by running. And as a matter of fact, running probably contributes to you keeping the knees as long as you did. For example, I had a great guy recently, older guy, nearing 80, said, I need this replacement because I ran marathons for so long. I'm like, no, you're 80 this long. Exactly. You kept your knee this long because you ran marathons, right? You got to flip the script on these people. Because of course they've been told by their doctors, friends, and everyone else, you're killing your knees from running. And that's just not true. So these folks with mild arthritis or moderate osteoarthritis, they're worried they're going to make it worse. They can rest assured that, again, the dose matters, right? I'm not going to say go run a 100-mile race, but you can return to running, and you can run as far as you want, as long as you want, as long as the pain is tolerable.
And you're not limping.
You shouldn't. No, exactly. You shouldn't have to change your cadence, your stride, your gait, because of the pain. And I don't want you stomping on the heel on one side, pushing off on the toe on the other, right? You have to be able to keep that gait steady. And if you can do that, great. And if not, you want to cross train and sit on a bike, go ahead.
Well, I try to encourage folks, and again, correct me if this is the wrong advice, but I encourage folks, think of your car when your tires are unbalanced. It damages the car to continue. When your tires are balanced, and that's the knee injury. So if you're limping, yes, you're probably damaging something. You're because you're throwing off all of your mechanics from low back to foot and ankle, et cetera, et cetera. But if you're running with that slight swelling and you're not limping, it's your normal gait, it's your normal cadence, your tires are in balance.
No, it's true. Yeah. We call it a kinetic chain, right? Because one joint affects the joint above, affects the joint above, et cetera. So yeah, that's why I don't like people to run with gait abnormalities. And I will ask them to wait. They rarely do, but I will at least ask them to.
It's in the record. All right. So I've had a bunch, you and I run with a lot of the same crowd, a bunch of the friends that are endurance athletes in their 60s with hip replacements. Now, I looked up the data, and this may be not perfectly accurate, but somewhere around 3% of the U.S. population over 60 will have total hip replacements. So maybe I'm just getting selection bias. I just know so many people that when I see somebody, I'm like, oh my gosh. And it's really probably a similar percent. But certainly some people would suggest that endurance training increases your likelihood of total hip and knee replacements. You've touched on this with the marathon comment with the 80-year-old. Any other feedback on increasing likelihood due to a lifetime or a couple of decades of endurance sports, running, triathlon, wherever you want to take that?
Absent any significant injury, no, I don't agree with that. No.
Okay, good.
I think it's the opposite. I think that if you think of all the healthier behaviors and conditions and our overall health and metabolic health associated with that running, again, within reason, there's no harm. The worst advice that you could tell someone with osteoarthritis is to rest. Because not only, and this enters into the equation when we're talking to patients who are contemplating a joint replacement, hip or knee, because they're often told by medical people or friends, wait until the very last moment until you can't take it anymore. Okay. So let's take a 60-year-old who is crippled by their arthritic pain, hip or knee. But they can get to work. They can hobble around the kitchen. They move their bedroom downstairs so they don't have to go up the stairs. Now, so that person can exist like this. But one, they're not living, but that might be okay for them. But there comes a point where the burden of osteoarthritis becomes much more than a manifestation of pain, because now you're not going out to eat with your friends anymore. You're not going out to eat with your spouse or your kids. You're avoiding many activities because you're not sure where you're going to park, how far you're going to have to walk, etc. You're home. You're probably going to eat more because what else do we do when we're home? Sure. You're sitting around. So you're gaining weight. Your blood pressure is going up. You're becoming more insulin resistant. You're developing fatty liver. Your risk of dementia, heart attack, and everything else is now higher. We didn't even talk about the loss of muscle mass and strength, which has extraordinary impact on us as we age. Anyone who's had a hip or knee replacement, hip replacements will recover a lot faster than a knee replacement.
Is that right?
They'll be sleeping faster. They're up and walking sooner on average. I know you did great. So yeah, okay, fine. I'm glad. But everyone else, after seeing 20,000 of these, hips do much better, much faster. And in general have a higher quote unquote success rate, right? So about 80% of people who had a knee replacement are really happy. Another 10% are okay. I'm good. It's better than it was. Thank you. And 10% are like, no. I wish I hadn't done this. So there are a fair number of people who are pretty unhappy. And, it's funny, as I like to explain to patients, when they see us in the office before surgery, all they like to point out are all the patients who didn't do well.
Yes.
Who they know. But about 2 months after surgery, they want to know why everyone else is better than them and doing much better. Yeah. So, the face of what we compare ourselves to changes. But these are long recoveries, especially for knee replacements. And what we need to maintain to be able to get through that is the desire to do the rehab, the desire to recover. So a certain degree of mental fortitude and strength. And we need to have physical strength, right? The best thing that you can do for yourself before hip or knee replacement is to exercise, to work with a physical therapist
beforehand.
A lot of people.
Rehab, interesting.
Oh, absolutely. It'll set the stage for a better recovery. And people who undergo prehab or rehab boot with a therapist prior to surgery will clearly recover faster.
What about some of the other complementary elements? So with Catalyst Coaching 360, we do a coaching program pre-surgery and post, and it's just maybe 4 coaching sessions, but it hits on things like protein intake. It hits on things like you're talking about activity levels, alcohol intake, sleep schedules, some of those elements. Have you explored that, or are you aware of any studies that have identified what you're saying, that your post is based on your pre in many ways?
Without a doubt. So I ask people to ramp up their protein intake.
Excellent.
Pre and post surgery, we become highly catabolic. The majority of hip and knee replacement patients will actually start to lose weight in the first few weeks. And I imagine, I haven't proven it, but I imagine a lot of that is lean muscle mass too. So it's absolutely critical to protect that. So let's get back to the person who really is in pain, hasn't recovered with therapy or injections or nerve ablations or anything else. And in these people who have reached a point where their pain is significantly interfering with their quality of life, they need to start to think about when to have their hip or knee replacement. You want this to be an electively scheduled procedure, because I've seen far too many people in my life who waited so long that now they can't get out of bed. Yeah. Right? They're on crutches or on a walker. They're asking for oxycodone. Right. And their health is very poor, and their ability to fight through the recovery is diminished. And it's an urgent situation. You may not medically optimize them. They won't get a chance to do prehab. They can't exercise without too much pain. And so the impact of all these things that we can do preoperatively will affect your infection risk, your recovery speed, protect your muscle mass, and enhance the recovery as much as we can. So it's very important that it stay as a controlled ambulatory scheduled surgery as opposed to something that's more urgent. We see this a lot in our elderly folks too. So you see someone in their 70s, mid 70s, not the best physical specimen, the kids in the family, like, you have to avoid surgery, don't do it. And you see them back 8 years, now they're in a wheelchair, right? And they've been there for 5 years. And there's no muscle mass. There's nothing. Can we replace that knee? Sure. But are they going to recover and get out of that wheelchair? Highly unlikely. Right. So, it's all pain management at that point.
So is that the piece?
Unfortunate circumstances.
Is it the quality of life piece that you're really emphasizing? It's not the pain?
Yeah. No, but the pain
can
the
shift
limitations and the loneliness and depression, is very real. And all these burdens on our physical stamina, our mental stamina, our cognitive health, our behavioral health really can clobber someone if things start to spiral. And all those things will affect their ability to recover from the surgery.
Absolutely.
So I've seen people for second opinions because they play tennis and they can no longer play 3 sets, only 2. And they're asking me, do I agree that they need a hip replacement? No, of course not. Right. But, there are plenty of people who, are told too early to have joint replacements, but there are, I think, more people who tend to wait too long. And in this situation, quite interestingly, it tends to be women. It's always fascinating. I could have middle-aged man in my practice, terrible pain, says, I'm gonna have a knee replacement. I'm like, okay, we discussed the surgery, the risks. I gave him a book, etc. I'm like, why don't you talk to your family, call us, set it. And he's like, no, I'll set a date now. I'm like, okay, fine. The woman in my office is going to delay things. My granddaughter, I have to help my daughter with the grandchildren. I have to help my husband. He needs my help. I have to help my mom.
Graduation's
I have
coming
to help.
up. Yeah.
They have to help everyone.
Yeah.
Right. And people who have daughters live longer because the daughters are better. But so sorry if I upset anyone with this, but it's true, and that turns out that women do tend to wait a little too long, and very often I will receive a telephone call, often from a woman. I can go ahead with surgery now. My husband passed, or my husband is now in a facility, or whatever. Right, whatever the life event was that they were waiting for has materialized. So they often delay significantly.
Well, and I was going to use the word no. We surmise that women have a higher pain tolerance from many of the studies out there. So that may be part of it too, where they're saying, I can, because these other people are important to me, and I can tolerate this pain level. But your recommendation, your encouragement to these folks is realize or take the longer term perspective of, in order to serve those around you that you love so much, we need to get you back to being you.
Yeah. So I try to flip the script to some degree. Yes, it's important as an adult, as a human, to see the needs, that others have, and to help them learn, mature, be properly cared for and educated, etc. But we also need to understand the influence that our health will have on that equation, right? So the more mobile we are, the healthier that we are, the more fit that we are, the better that we are the better able we are to assist those of us around us.
Right.
And that can be challenging. Absolutely. Sure. I get it. And and those situations exist. But I think far too many people fall into that trap where it doesn't exist. They can work it out so they could have their hip and knee replacement, yet they don't.
And get back. What about revisions? Are there technology shifts? The person that ended up getting a hip replacement or knee replacement in their fill in the blanks, 50s, early 60s, and then they've gotten active again, and I want to talk about that in a moment. But at what point do you need another one? Or, bionic man here? When are we going back to create that $6 million man again?
Yeah. So they are metal and plastic pieces. So they do have a limited lifespan, but despite that, it's quite long.
And does activity level influence that? Does the person that gets back to ultra running or cycling or whatever reduce that down from 30 years to 20 to 15?
Sure.
Okay.
Yeah, because it is a matter of cycles, right? The more miles you run your car, the faster it's going to wear out.
So it's different than because we talked about the joint itself you're
Correct.
extending it out.
Biological joint.
But the replacement is not.
Joint
yes,
now.
Perfect. That's important.
Right. It's not biological now, it's mechanical. So we do need to consider that. But I couldn't give you, I don't think anyone could give you hard and fast numbers on just how many miles you can run.
Right.
You know, I
need an oil replacement at 3,000 miles. Yeah, I got you.
We can't do that. And while I'll tell most runners who are interested in running that, sure, you can, slog along, for a few miles, a few days a week, you may not be able to. So while runners can run and are often allowed to run, we try to limit the frequency, we try to limit the mileage, and sadly, many runners just can't run. It's more likely that you'll be able to, it's more likely that you'll be able to run with a hip versus a knee replacement. But I know you've all seen people try to play professional tennis and football with these things, but I assure you there are a lot of orthopedic surgeons in the background cringing at what these people were doing, because it wasn't in the best interest of that joint's longevity.
And I naturally think of Bo Jackson. Did that shift?
Of course.
Because I don't even, what year was that? Late 70s, early 80s?
No, it had to be in the 80s.
Okay. So did that change the perspective when all of a sudden this Superman at 29 was getting a hip replacement? No. Or was it a scientific? Were you all watching and like, okay, this is going to guide our approach to the everyday person?
No, I mean, you really want to avoid joint replacements in very young people. So there needs to be a good reason for it. He had one, right? He dislocated his hip. So he had what's called osteonecrosis, where the bone dies because of loss of blood supply. So the hip collapses and you really just don't have an option at that point. But if we're going to try a lot to get our 40-somethings and 50-somethings a few more years out before we think about their joint replacement, there's some recent data on the need for revision in knee replacements, and the revision risk under 55, I think it was very high. And all these young folks think, oh, I'm going to do great. I'm going to do better than these older people. And no, because it's a bigger procedure, right? More muscle, more tissue. It's a little more of an operation.
The knee is.
And correct. Yeah. And more so, their expectations and demands are off the charts. Right. They're still at the age where they remembered playing football in high school, running around the soccer field with their kids. And for many, that's what they anticipate they're going to be able to return to. So I definitely see a lower satisfaction rate in very young people, but that is closely tied to what their expectations and goals were. So anyone, and actually, for most people, I will ask them, why are we doing this joint replacement, right? Is it to, restore your ability to walk, to sleep comfortably, to get out of bed and not worry about falling, to ambulate on stairs, to go out with friends, right? To return to life, and the gym on occasion, great. Those are my favorites. When people start to mention running, tennis, golf, hips can usually hit them. Okay. So those expectations. Knees, maybe not. We just don't know. So you want to control those expectations, because if the patient is living a life of regret, that's an awful place to be.
So my follow-up question was going to be, and I think you've answered it for the most part, is what can the person with the total knee, total hip expect, or how can they optimize their training? But what I'm hearing you saying is, okay, Brad, you're a sub 40 10K guy now. If we do a total hip on you in 2 years, you're never going to, you actually total hip, you might be in the ballpark. Total knee, you'll never approach that again.
Yeah. I wouldn't guarantee you that you go sub 40 on a 10K. There's no way. With a hip replacement, there's zero chance that you do it with a knee replacement.
Interesting. Okay.
Zero.
So,
Negative
and that may be
zero.
motivation for folks too, that are on that fence and thinking, I still do want to play that tennis, or I do want to run faster. Let me see how I can do.
If you're still running, cycling, still on the tennis court, still walking a golf course, playing Frisbee, diving in the ocean, I find it very hard to suggest a hip and knee replacement to these people.
That's good advice.
I just think they're setting themselves up for expectation failure.
Right.
And this is a very, people want to know about the risk of infection, or where someone trained or went to school. Look, I mean, first of all, the chances that you need to travel for a joint replacement are very low.
Is that right?
And in most metropolitan areas, yeah, you don't need to travel to a big city. But you need to discuss whether or not your goals or expectations match those of your surgeons, and push them on this, because this is absolutely critical. Because most surgeons who are doing these haven't had one.
Right.
So we don't understand the
Great
struggles.
Point. Absolutely. Yeah.
I mean, in my entire career, I've never used a PA in the office the way that others do. Granted, it's not, the path to riches, sure, but it's okay. I wanted to see my patients after surgery. Why? Because the surgery is not a success to me if the components are in well, right? So I don't judge the surgery as success when we staple the skin and we wake you up.
Right.
I judged whether or not that surgery is a success if after 3, 4 or 5 months, you say thank you, and you have a smile on your face and everything else. Right. And I'm not going to know that if I do the surgery, and you're one of 10 in that day, and you see my, you see my PA instead of me, because I don't get that follow up. And right. Furthermore, I don't get the feedback
that's what I was saying. It sounds like a feedback loop.
Exactly. Right. I need the feedback to better inform the next patient who's thinking about it, to know what your challenges are, what you can and cannot do, when you can and cannot do it, and so on. And that's hard if I'm not seeing you after surgery.
Yeah. All right, I'm going to pivot. We've just got a few minutes left here. You've been talking a lot more. And if you're not following him on Twitter, you got to follow this guy on Twitter. Like, the guy, it's awesome. So we'll have a link to his Twitter account. It's at HJ Lukes. Is that right? Just off the top of my head.
Yes.
Okay. But you've been talking more about power. So not just strength, not just muscle mass, but the importance of power as we age. Talk us through that a little bit, maybe how to measure it, what types of training would influence this, those types of things. Just kind of give us an overview that'll allow people to go, ooh, I need to look into that more.
Yeah. So if you're over 50, you need to look into that more.
Yes.
Plain and simple, right? Strength training is critically important. We've all discussed how important the maintenance of muscle mass is and strength, right? Peter Attia talks about training for the octogenarian Olympics, right? Or the centenarian Olympics, right? What do you want to be able to do in your 80s and beyond? Well, you're not going to kick ass in your 80s if you're not kicking ass in your 50s and 60s.
Right.
And many people just think that squatting, deadlifts, benching, and curls are going to get you there. And that absolutely is going to improve your strength. And strength is necessary to a point, right? I'm 61. I can still bench 225 or more, but I don't. I concentrate now far more on power, quickness, and agility. Why? Because power is the application of strength quickly, right? It's being able to jump up a bunch of stairs. It's being able to do, they're called plyometrics, like a box jump, right? That's the application of power. So you need the quadriceps strength to do it, but you need the power and quickness. It's being able to sprint. It's being able to lift something, or catch something that's falling. It's being able to, the most important thing, the reason why I bring it up is because falling is a very common cause of death.
Yes.
It's not the fall, let's say, right? You're not going to bang your head and die of a hemorrhage, although you might. But there's a lot of things that led to that fall, right? Deconditioning, loss of power and strength.
Balance.
But that fall initiates a process, because let's say you spend a week in bed because of that fall.
Right.
And if you're 70-something, you may. You're going to lose 6 to 8% more of your muscle mass and strength. Okay, so when you get up, you're not going to go to rehab for 4 months to get back to your previous baseline.
Right.
Sorry, your baseline is now lower. So now you're at higher risk of tripping and falling. You're going to. Let's say you break a hip. You're in the hospital for a week. You're in rehab for 2 months. You're not getting enough rehab to help you back. Now you're in a wheelchair or you're on a walker. You sit around a lot. You're going to get pneumonia, urinary tract infection, and you're going to die. 50%, upwards of 50% of people who fractured their femur as middle and older age adults are dead within a year.
Wow. That's a huge
Well, it's 30 to 50%, depending on the study. And it's a lot of it is because you're not properly rehabbed. Rehab doesn't end when you can get up and walk with a walker.
Right.
And so let's go back to power. So if you trip and stumble, because our balance goes to crap as we get older, we can all attest to that. You're going to trip and stumble. How fast is that leg getting out in front of you? How fast? So you're doing a lunge, right? Under power. And that leg should be able to stop you. You should be able to have the balance of staying in that position and not falling over. And not only that, but you should be able to push yourself back up. So that movement is all power-based. So training power, it enables you, it improves your ability, day-to-day activities. You bounce up the stairs. I'm not talking about running and jumping them, but you just feel fully capable of bounding upstairs. You can change directions on the tennis court quickly. If you're a trail runner, you can bounce from rock to root and feel really secure. So it has applications throughout our daily lives. But the biggest one is it will save your life one day, because if you can prevent the fall, you can prevent a very significant set of consequences that are going to follow in a reproducible manner. I've seen this movie play out far too often.
Yeah. If you were going to give the person listening who's going, ooh, I can do that, I'm in the gym, maybe 3 things to start with. Would you start with small box jumps, some medicine ball tosses? What would be maybe your 3 starting point?
Sure. So I love medicine ball work. I do. I have a regimen, with medicine balls where I'll squat down and throw it up to the ceiling, as hard fast as I can. I'll face the wall and I'll throw it into the wall as fast and hard as I can. I'll face the wall with my left side and throw it, with my right arm, switch it up and throw with the left arm. I take medicine balls and swing to the side, just back and forth, not releasing the ball. That's often harder.
Because you have to decelerate. Yeah, that makes sense.
Exactly. It's all eccentric. Then I have a set of plyometrics that I do with either kettlebells or dumbbells. So, and these aren't heavy. I'll grab 25-pound dumbbells or kettlebells and I'll do jump squats.
Interesting. So
just boom.
40 to 50 pounds in your hands. Go. Yeah, that makes sense.
And jump as high. It could be 20 pounds. Yeah. It doesn't matter.
Yeah. It could just be jumping to start with. It just jump. Absolutely. Jump, grab the jump rope.
Correct.
Yeah.
Absolutely. You can do jump squats, speed skaters, all those warm-up drills that you see football players and runners do. You can just do those. These are all blending strength and quickness and power. But it's critically important. So one day a week now, I do strength training, just pure strength training. And the other two are mixed. So some strength, some power, a lot of single leg work, so that I'm pushing the balance component as well.
Love it. And we'll wrap up here. I appreciate your time. We could go so long. That's why we've had you back. This is the third time. But just an encouragement to folks, I notice with the plyometrics, it's not just a have to do or I should do. I just feel better as a runner when I've been incorporating the plyometrics and the box jumps and the little jump rope. You just feel better once you get through the first few sessions.
Absolutely.
Yeah.
And they're fun.
Yeah. Exactly.
They're a lot of fun. A set of medicine ball exercises is really a lot of fun.
Awesome. Doc, thank you so much. Great to see you. Love what you're doing. Keep it up.
Thanks, Brad. Appreciate it.
It's been a pleasure getting to know Dr. Lukes and following his work over the years since he first joined us back in February of 2020. Again, his book is titled Longevity Simplified, and we'll have a link to that below. Thanks for tuning into the #1 podcast for health and wellness coaching, and thank you for sharing it with others. You literally have millions of podcasts available at your fingertips, so it means a lot to have you choose to spend a few minutes of your week with us. As always, feel free to reach out with any questions about your current or future coaching career, how the National Board Certification works, specialty certification options, and our annual coaching retreat and symposium in beautiful Estes Park, Colorado, as well as much more. That's over on our Institute site at catalystcoachinginstitute.com, or reach out anytime if you'd like to chat. Results at catalystcoachinginstitute.com. We'll set up some time. And now, it's time to be a catalyst. This is Dr. Brad Cooper of Catalyst Coaching 360. I will speak with you soon on another episode of the Catalyst 360 podcast, or maybe over on the YouTube coaching channel.